one of my favorite topics to talk about, and I love the panel we've got here today. So I'll jump right in. This is such an on-point thing to talk about because there's so much news about retailers getting into healthcare right now. And it stands to reason. You know, healthcare spend is driven very often by things that are happening outside the four walls of healthcare. And the traditional system sometimes struggles to influence those things. So we've seen the emergence of digital and retail health. We've seen all the deals happening out there. CVS getting into home-based risk adjustment with Signify, paying $10 billion, doing the Oak Street deal. Walgreens doing a series of deals as well. So we're going to be talking about a couple of things here. Retailers are moving into healthcare, certainly, but healthcare is also becoming more retail. So we're going to discuss why. We're going to discuss some of the rationale behind that, what's really happening behind the scenes, and you're going to get a perspective from these folks who have seen retail clinics, the payer perspective, and pharmacy and retailer perspective getting into healthcare. So with that, we're going to start off with Webb. This is sort of a very sizzly topic right now, but it's not new. The notion of retail-based healthcare is not brand new. It's been around for a while, and you've been doing this for a long time, since the early 2000s. So give us a little bit of that background and what you've seen along the way, because it's certainly evolved, and you've seen what works and what doesn't work.
Yeah, well, I'm going to date myself here.
Go ahead.
About 20 years ago, I started a company called Ready Clinic, which was one of the first companies to put healthcare clinics inside retail outlets. And we opened our first clinic in 2005 at an H-E-B grocery store in Houston, and then subsequently a lot of other H-E-B stores. We also operated clinics in Walmart stores in Arkansas and Oklahoma, in Dwayne Reed stores, actually before Walgreens purchased it, and in Walgreens stores in Atlanta. And then the company was bought by Rite Aid in 2014. Subsequently, I became CEO of FastMed, and until we got into a sale process recently, we were operating 170 clinics, freestanding urgent care clinics throughout the United States. So in one case, we were in the retail-based clinic business. In the other case, current case, as you suggested, we're in the retail medicine business. And it's been a wild ride, actually. But the thing that kept us going was that patients loved it, from the beginning. They loved the convenience, open 7 days a week, extended weekday hours. You can get it in and out quickly because we had a limited scope of practice. And that's kind of what basically got us through thick and thin. But the business model has always been a bit challenging for a variety of reasons that I'm sure we'll discuss. But we had a limited scope of practice because we had limited space. We weren't mostly not using physicians, but APPs. And so it was hard to expand from a very limited scope of practice, even though there was an opportunity to do that without violating the basic sort of business model of being able to get people in and out in a 15 or 20 minute interval. And so, I've seen a lot of different approaches to retail medicine over the years. I think it's a permanent part of the landscape now. There's no question about it. There's much more innovation in this space. I think virtual care has been an important enhancement because it's really playing again into consumers' desire for convenience. But of course, you can't treat everything virtually. So I think an omni-channel strategy makes sense. So we treat you virtually if we can. If not, there's a clinic down the street. I think the move into primary care makes sense because so many of our patients told us that they don't have access to primary care physicians. And you can see a lot of those things, being played out here, but nobody has figured it out completely. So it's still a work in process.
Absolutely. I think it makes sense that healthcare is becoming more retail given the convenience and consumer demand, but retail also becoming more healthcare oriented. Is that about capitalizing on the fact that the consumers are in the stores, in Walgreens stores and CVS stores and Walmart, multiple times a month, whereas they may not be in their primary care provider maybe once a year? Or is it about the economics of higher margin services becoming holding companies to offset the pressure that the pharmacy's under?
Yeah, I think it's a great question, Mary, and I think it's multifaceted. So I'll start with the first piece around what Webb mentioned. It's convenient. And I will tell you that especially during the pandemic, we saw that, right? When consumers and patients couldn't get in to see their primary care physicians to get vaccinated, they were able to do that at the pharmacies. And so for us, frankly, it gave us a right to win and say, if they're coming to us and they're seeking these services, what else can we do? So I would start with the first piece around convenience and healthcare being so local and very, there is definitely a face-to-face aspect. So that's one. We saw that the patients were coming to us. The second piece, and the example you used, right, the economics. So if you're sitting on 9,000 retail locations and you've got a vast footprint, and you have, the Amazons of the world where you can get a lot of the front store stuff within an hour, 2 hours. And so how do you think about that footprint differently? And how do you capitalize, right? And so that becomes both a combination of we can do more, patients and consumers want more healthcare services. To your point, the average person visits their primary care physician 2.5 times a year. Mm-hmm. They come to the pharmacy 7 times a year. 80% of pharmacy consumers say that they would come to the pharmacy for health and wellness. Mm-hmm. So I think there's preference, and the economics make sense because we have to start thinking about our stores as more of a healthcare destination and grab a bigger share of the healthcare dollar.
And I've read somewhere that retailers may be a third or so of the primary care market very soon because of the increase in utilization in primary care in those sites. Clearly, yep. People want it. Yep. Seth, from the payer perspective, you've got a very interesting perspective as a payer, but you're also a payer that's got a JV or ownership in Anita's clinics, and you were, I think, really innovative and ahead of your time during the ACA and putting up retail centers across the state of Florida. So you see this from multiple different angles. Speak to the kind of retailization from your side.
Well, I think there's so many good things about the concept of bringing more retail mindset and a lens to healthcare. Most of us would agree, it's fragmented, it's not easy to use, it's clunky. I routinely have lots of conversations with the head of our digital portals and stuff because I'm like, I can go to Amazon and see like everything I need to know about a backpack. But when I'm trying to pick a doctor that I need a specialist for my daughter, like, do you know how hard it still is to figure out like who to go to? So I think that the lens that the retail concepts bring to healthcare are really important and could be really valuable. At the same time, there is the connectivity, all the issues that we know of stitching that behind the scenes back together. And Walter and John actually talked a lot about that in the first session this morning about how to make those things connect. And so from GuideWell's perspective, and GuideWell is the parent company of Florida Blue and SSS, we feel like we have learned tremendous amounts about ourselves and about our consumers by also getting into the delivery space. So we have, as you mentioned, Mary, about 45 or so clinics. We see about 400 and some thousand of our patients that are indexed to that, and then probably another 200,000 or so in own clinics and delivery mechanisms that we have as a plan. And we see in every case that the consumer trusts us more and is more engaged, and we have higher NPS scores when they have that combination of interaction. We've also launched, as you mentioned early on, because Florida competes very heavily in the ACA market. These are individual decisions that are kind of marketed and determined by individual choice. And so we have about 10%, I think we provide about 10% of the exchange business for the nation in Florida. And so we've been in that business for some time. Early on, Pat Garrity, our CEO, who's been an amazing visionary, had started retail centers. And these retail centers are places where people will see the Florida Blue brand, but they can come in for anything, and they do. And so we hold yoga classes, and we use those centers for like community activities, and we connect with nonprofit other providers. And so it's, when I talked to our head of retail and I said, like, what would you want me to say when I'm talking to my friends here? And he said, I want you to say two things. One, some of our proudest moments are things like helping a parent that has a very difficult time making ends meet find sponsored daycare for their kids so they can work and provide for their family. That's sometimes what they do. So we view ourselves as a solutions company, not just providing health insurance. The second is, and I shared this with Mary earlier, but he actually texted me a picture of a person holding a certificate, and he said, you know what that is? That is a person that is now a U.S. citizen because we helped them become a U.S. citizen. And I thought that was just such a really, some cool examples of how when you have this different mindset and you're kind of in the fabric of the community, and certainly Walgreens stores are definitely in the community. And so from a retail perspective, you have so much more access, and that you can do more than just your traditional job that you've been doing or what's made you successful so far. But we have to think differently, and that's been certainly what we've heard all day from people is like, how do you get into a different space and think differently? How do we bring more value to the consumer? So I hope that's helpful.
It's very helpful, and I think there's a lot of very positive, typically positive discussion about retailers getting into healthcare and the role of retail clinics for those reasons. Let's talk about what could go wrong and what doesn't work about it. You all have a different perspective on this. You, Anita, are sitting in the role that is meant to integrate very different assets across an organization. And those assets have very, very different money flows and pressures. And, selling toothpaste is very different than running Village MD, front store, back store in the pharmacy. That's a lot to reconcile. And we were discussing this last night. And you and I were both at CVS at the same time when we removed tobacco from stores. That is something that a retailer can do in 2 days in an extremely efficient way. Standardized ops are really, really second nature to retailers. But healthcare is really complex. It's very different. The money flows in a different way. So what isn't going to work and what could go wrong here, just to push on the other side of this?
Yeah, I'll start. I think it can work and it should work. I would say it starts with ensuring that the incentives are aligned. I mean, it all goes back. I think you think about all the conversations we had today. If you put the patient and the consumer in the middle and ensure that the incentives are aligned. I'll give you an example. Historically, Walgreens had some other retail clinics. And it's not even primary care or urgent care. It was, let's say, optical or hearing. And that model was, we're going to give you space, we'll collect rent, you do your service, bye. And you wonder why we exited those, because there wasn't a shared incentive to say, let's put this patient in the middle. They're going to have other needs. How do we integrate and connect them to the rest of the ecosystem? So now fast forward and we have Village MD, and we have partnerships with other health systems too, where now it's really about how do we take care of that patient in the middle. If they need pharmacy, they can go and get pharmacy services. If you realize that they need a specialist, we refer them in. If they need post-acute care services, we have CareCentrics. If they need DME. So I think if you really start connecting, and it doesn't mean integrate, because as long as you put the patient, you've got the right experience, you have the right technology to make sure you understand their needs, and then you're able to help coordinate. I like what Walter said earlier. It's how do you become that care navigation? Because that's what they expect. They expect when they come to Walgreens, I don't care if it's someone else with a space and delivering the service, I expect you to take care of all of my needs. And so I think that's what we're trying to do. It's not easy. It's hard, to your point. The economics don't always flow through. And that's where if you can go at risk, and if you're really rewarded for performance, I think it starts to shift the model.
What could go wrong?
Well, a lot did go wrong at various times. And we were, at an advantage and a disadvantage in that we didn't have, until we sold the company to Rite Aid, we did not have a strategic partner. So we didn't have a CVS or a Walgreens. And so we had to figure out how to make a business out of it. And it's a tough business because, it's a low margin business. And it depends upon, high patient volume consistently, and with a very lean staff. And it's one of those things that the value proposition is pretty clear and simple, but operating at its scale is not. But we did, ultimately figure it out, and I think satisfied that, that it's possible and can even be a good business. But one of the things I felt from the beginning is that, even though we had significant advantages in terms of accessibility and convenience, the fact that we had a limited scope of practice sort of obligated us to figure out how to connect to the ecosystem, in a more systematic way. And so over the years, we've done, between Ready Clinic and FastMed, more than a dozen joint ventures with major health systems. And that took a while to figure out that model too. But, clearly gave us the opportunity, if we were seeing a patient who had a condition that was outside of our limited scope of practice, it gave us a place to refer. And then on the other hand, as health systems needed more of a retail presence and got into the sort of ACO, value-based care business, it gave them, opportunities to refer patients to the lowest cost point of care, also worked for our payer partners. So it's important to be part of the ecosystem, and we can't lose sight of that, either in terms of the business itself or in terms of putting the patient in the middle of it.
Yeah, I think you're right. A lot can go wrong. I think that the alignment of values that John touched on is like one of the ways of avoiding things going wrong. And I'd say what we've seen is like some of the capital-backed investor, a lot of the point solutions, the drive for kind of the capital model to win is not always aligned with affordability. And so really making sure we have the right partners around the table. And it doesn't mean that can't work. It just makes sure that the right partners, the right incentives, the right alignment. The second thing is really knowing yourself. And so I think I saw Chuck joined us just a few minutes ago, Chuck DeVito, who's the president of Florida Blue Commercial. And, he made some really big decisions early on around how we were partnering in the provider space to bring in partners that really knew what they were doing in the provider space instead of trying the plan figured out and leveraging the way the provider skills and talents came to the table, kind of like you guys buying Village MD, and then bringing the plan expertise and joining to make something that was far better when we brought both of those skills together than trying to force it from one ownership. So I think what could go wrong in retail is treating it just like everything else we've done in retail and trying to make it work on, a volume generation model or something like that that's not conducive to driving affordability in healthcare.
So to that point, the conference has harmony themes. How best should, whether it's a retail clinic or Walgreens or CVS or Amazon in one, how best to work with the rest of the system in a way that really is effective? Where should the lines be drawn? Because I'm hearing undertones of retail's not going to fix everything. There's not one player tech's not going to come in and fix healthcare, and retail's not going to come in and fix healthcare. And we talk about these things as if there's some magic thing that's going to happen. Were we talking about the gem earlier, looking at it from different angles? That was someone else. So, no one is going to come in and just fix everything, right? But there are different approaches happening. CVS is taking the approach that, we have to own the payer, got to own the premium, and then fill in those assets. Walgreens is taking a more neutral approach in market. And then we've talked about some of these approaches. So where should it start and stop? What's the right approach here? So that we're not threatening the traditional system too much, but we're getting out of the traditional system what we should be.
Yeah, I mean, I think the opportunity is to enhance the traditional system, really.
Yeah.
And that's, I mentioned the joint ventures we've done with major health systems, but one of the other steps we took a couple of years ago was to be the first independent urgent care operator to adopt Epic. And there are a lot of reasons why we made that decision.
Yeah.
But one of them was to make sure that we could be part of the ecosystem and really be sharing records. And it was a bold move, and would have been a heavy lift anyway, except what we didn't know when we made the decision in late 2019 was that the pandemic was around the corner. And so we ended up having to do a lot of the implementation virtually. But we did do it, and we've spent the past couple of years optimizing the system and really figuring out, how to use it to really become an active, part of the ecosystem. And I'm not saying this is the only solution, but that's how committed we were to being part of the ecosystem. I don't think it's fair to the patient not to be, and I think there are economic advantages to being part of it. And the one thing you don't want to be is not part of it in some way, economically or otherwise. Yeah,
Mary, I'll add, and I think you teed this up, from our perspective, it's partner with everyone. And we really feel agnostic about that. And I'll give you two examples. And I would say a combination of that with know your space, know where you have a right to win, know where the patient's going to come to you, what do they want you to do, and where you need to actually partner with best-in-class organizations because that's not what you do well. And so, we partner with a plan, simple care gap closure for colorectal screening. They were not having tremendous success. We did joint marketing, joint campaigns. We said you can come receive these kits at the pharmacy. We'll help someone, they'll walk you through what to do. We saw double the conversion rate. Now that's a great example of when someone's either calling you or sending you an email and saying, hey, you need to do the screening, call to get a kit. We weren't getting that traction. I think the rates were maybe 37% completed it when they received an email, 70% completed when they came into a Walgreens. And that was done within 4 months, right? So that's great. We have our space. We have healthcare advisors. We've created a healthcare destination within some of our stores where you can help close some of those care gap closures. So that's an example of where we're partnering with a plan. We want to be an extension of what they want to do. And it's come use our footprint to drive better outcomes and to close those gaps. The other example I'll give you, now this is not about our physical footprint, but it's about our brand. Another example, working with a plan after hospital discharge, and we know that a lot of patients are readmitted within 30 days. One of the major issues is medication related. And so we worked with them. And so there's patients who they cannot reach. They've tried 2 or 3 times. They're not picking up the phone. They don't want to do a med rec. Now we're using Walgreens pharmacists, the Walgreens telephonic outreach. The reach rate was 80% compared to 30%. Huge. And that was, it's not saying come into our stores to do MedRec because no one wants to sit for 45 minutes and talk about all their medications. That's an example of it's actually more efficient to do it telephonically, but the brand mattered. They picked up the phone and they had the conversation with their trusted pharmacist. So know where and when to influence, right? So those are examples. And we do that on behalf of plans and systems.
But so I love that example. Are you thinking as a payer, okay, we've got these low screening rates, or we've got, Blues have a different brand than some of the nationals, because you're really well known in your local communities and whatnot, but where to leverage another brand to get what you need done for your patients and for your members? Are you thinking like that to connect into your
if not, we
retail partners? Exactly.
I feel like this is leading the witness. Does anybody else feel like I'm being led down a path? I would say it's not just the brand. The brand is important, and obviously getting the access. And so where I'd say brand is probably really important is, especially like for ASO patients that are, or clients that are choosing a product because it has a name brand recognition. But I think what Walter was saying this morning is it's not just about the brand that's helping you do this. It's about how do you stitch that together and how do you use the infrastructure, as Webb said, that's there. And so what I'd say is the way we're thinking about it is clearly we've heard the discussion around partnerships all day. That is absolutely core, but it's also hard. I think what we would say is we're focusing on places where partners bring more to the table, do it better, faster, less expensively than we can do it ourselves, and being humble enough to say that's somebody that we should be partnering with. That's not always easy, especially for me. But to really just, again, know yourself, know what you're good at. And then I think across the healthcare system, just starting to stitch together those pieces, like who's best at this and who can do this the best, and how do you design things to make that happen? The last piece I'll say is just that this is a very connected problem, right? So when I used to, be in negotiations with, when I was a CFO of a health system, being in negotiations with commercial, we'd always talk about, well, can you help us with the Medicaid population or the uninsured population? Because, that's driving a lot of my ED costs. And, so you have this whole thing going on around cost shifting. And so it's we have to solve healthcare as a bigger issue, a bigger problem, and that's the place where I think retail has a little bit more of a struggle, because retailers are constrained in terms of margin expectations and capital returns. And there's a reason that there are nonprofit health plans, and why we have 340B programs and all of those things to support a safety net structure. But still thinking about how we work together to solve some of those problems more broadly is going to be really critical to driving overall affordability across the healthcare system.
What do you think the role, if any, or the impact of retail, whether retail clinics, retailers getting into healthcare, will be on provider shortages? Does this provide some scale and leverage for the system, or does it do the opposite?
Well, look, I think the workforce issues in healthcare, I'm sure it's been discussed over the last couple of days, are monumental. I've never seen them this challenging. And that's a problem that we all have, all providers have. And there are, we discussed in a smaller meeting yesterday, a number of us, what could we do about this? What could make it better when 20% of healthcare workers have basically left the industry over the past couple of years? And we were, with our 170 urgent care clinics, we were on the front lines of the pandemic. I think we treated considerably more than 2 million patients with COVID-related symptoms, and it just burnt out our clinic staff members. And they had the best of intentions and mission-driven company. They're mission-driven, but it just got to be so hard every day that even many of the best of them just said, I just can't do this anymore. And the workforce hasn't recovered, and I'm not sure that it's ever going to. So clearly leveraging technology here is part of the solution. I think, having people, team members practice at their top of their respective licenses is very important. We've got to do that. The system just cannot afford to have physicians doing things that nurse practitioners or physician assistants or nurses or pharmacists or any number of other healthcare workers could either do today or be trained to do. This is going to be I think the biggest challenge that the whole healthcare system has, and it's not unique to retail.
Yeah, I'd agree. And you all have seen in the news around, pharmacists shortage, pharmacists walking out. So
are you going to have to go back to?
Yeah, I would be extremely dangerous behind a counter. So they should never count on me to fill the shortage.
I feel about lawyering.
Yeah, but I think you're right. Technology is going to help, and I'll give you some examples of what we're doing. We're doing a lot of our the prescriptions that can be filled in a centralized location, we're taking those out. And I think John Driscoll mentioned that today. We've got 11 of those micro-fulfillment centers. You can get the prescription. It's not for your acute, so I want an antibiotic. Right now I'm going there, that'll be filled at the store. But a lot of the chronic medications that we know when the refills are coming up, it can be filled somewhere else. So it gives pharmacists more time. The second piece is, having worked many years ago behind the counter, one of the number one issues are some of the plan benefit issues, right? Our techs and our pharmacists are calling, there's a PA on this, there isn't a refill, they need to try something. So all of that, if we can remove noise in the system, I forget who was on the panel earlier today that talked about, they take all of those PAs out, it makes it really smooth. If we can do some of those, I think that will really help because they're not.
Prior auth.
And I don't think it's get rid of, but automate.
Yeah.
And if you have the data, don't keep asking the same question every 6 months, right? You have it. We should have a connected system where we can go and draw all that data. So I think those things will help. And you're absolutely right. We need our clinicians to practice at the top of their license. That's what they went to school for. That's what they want to do. That's what the patients expect them to do when they come to the counter or to a clinic. In an example, we're in some states, pharmacists can treat, diagnose and treat, especially upper respiratory infections, the flu. You don't want them going to urgent care, high cost, or primary care, right? It's influenza A or B, here's your Tamiflu. Everyone's happy. So I think to the extent we can use technology, we can practice at the top of the license, that helps with some of this workforce shortage, and then we just need to graduate more across these allied health.
Yeah, I think
Seth,
totally agree with you.
Prior auth?
What's that?
Can you fix prior auth?
Well, we're trying. That is actually something that's very high on our list, and we've been working with different people to help get more information to the physician at time of treatment, so they're actually making real-time decisions. They're not waiting to find answers from us sometime later. That's a game changer, for a physician to be able to say, right now, this is what you need, and know that you're going to leave the office and you're going to go right to that. You're not waiting 2 weeks to find out whether or not you can have the MRI, et cetera. And that is work that we have underway, and feel really strongly about that, and reducing the amount of administrative work. And I think the work that we've been able to do with Sanitas, as we talked about in that partnership, is trying to find out what are those things that we can take out of this equation that we don't need and make, and again, there's been discussion around better alignment. If they're making decisions and they have skin in the game, that these are their decisions, there's a lot more comfort of kind of pulling those, still got to have guardrails, but pulling as many out as you can. I think that's really important. The other piece is that in the health system side versus the payer, or now talking about large retailers coming to the market, there is this concept of how you use technology best. And so things that are like scalable tools, analytics, all these are just ripe for standardization and making things better, to then allow the physician to use those tools, but then individually apply medicine to the person in front of them real time. So I think that those are some ways that we're trying to make a difference and are actively investing in those types of solutions.
So we're dancing around technology investments. What about the role of digital in enabling all of this, digital plus retail? We talked the other day about the omni-channel experience, and that consumers really do want all of it. They want both.
Yeah.
They're not going one or the other. I think you said at the beginning, not going just virtual. They're not going just digital. So they want the retail experience, but there is a role for all of these things. How does it all fit together?
Yeah, I think that's right. I think you have to offer virtual because consumers want it, and they're going to increasingly want it, even though there was this surge during the pandemic, and then there was, a bit of a lull, but it's, virtual is here to stay. It's not new either. Telemedicine has been around for 30 years, at least, in being actively implemented in some provider organizations. And so it's come of age, but there's a limit to what you can treat virtually. I think that set is going to decrease over time, and virtual is going to become more important and have more of an impact. So I think you have to be careful about building more boxes, because there may not be as much need for as many boxes. I think what you need is to be very selective and make sure you have an omni-channel offering. And I really believe that what Walgreens and you guys are doing as well, and we are starting to do, moving into primary care makes all the sense in the world. I mean, patients need access to primary care. It's clearly a significant cost driver. Lack of access to primary care is a significant cost driver in the system. And I think, only a retail approach is going to fix this in a meaningful way. It's not going to get fixed any other way. I mean, I talk to physicians who are moving into these concierge practices, and that's great. I mean, it makes sense for physicians and it makes sense for the patients who can afford to be in those situations, but it's just going to take more primary care providers off the table. And so, I think retail has to step into the breach here, and it's also a big opportunity. It's, expands the addressable market. It reduces the seasonality of the business, historically. And, it's something that should be done and can be done, but not easy either.
Do you have to take risk to make that work?
Well, no, I don't think you have to in the short run. I think you want to in the long run. I mean, I'm a big believer in value-based care. I think now that, and this was another driver behind our decision to implement Epic, is to be able to have access to the data that you need to ultimately prepare to take risk, not just, upside, but potentially downside. And there are providers who are making money consistently in value-based contracting. And so it's definitely possible, and the system has to go that way. Mm-hmm. I mean, the amount of money that we spend, forgetting about, the other inefficiencies, the amount of money we spend in so-called revenue cycle is just, and that's wasted, is just ridiculous. Yeah. It's got to stop.
Mary, I want to go back to your last question, though, because you asked a very specific question about the labor, the availability of clinicians, and does this get better or worse? And I don't think it's really a question around whether retail enters that space and that's the driver or not. I think what the big opportunity for us is to not only help clinicians play at the top of their game, but for us to get a lot smarter about, well, who really needs to see who, and can you start segregating that population a lot differently? So that is also, things that we've been learning through our work with our partner Anita, is how they see patients and who they see in the office is really a big determinant of how that influences total cost and affordability. And you might only need to see certain patients either one time a year or maybe virtually, pretty easy check-in for healthy patients that have no needs. But for your higher acuity, where you're driving most of the costs in the healthcare system, you might need to see them every month, to keep them out of the hospital, keep them healthy. So I think that's another part of medicine that we have to get a lot better at as a team.
And I'll add to that. I think there's absolutely the piece around that predictive analytics or understanding. There's also a big piece around customer and patient preference. Mm-hmm. And I think that's what retailers know and understand really well in the data, right? Why is someone coming in? How do they want to be communicated? When do they want to be communicated? How? And so taking that and really personalizing the experience is important. I'm a firm believer that face-to-face and physical is important, but it's only one lever. You have to have the digital capabilities. You have to have virtual. You have to have home. You have to have community support, right? So all of that needs to come together. And the winners are going to be the ones that offer that great experience when someone needs it, the way they want it, based on whether it's a acute illness or a long, there's so much that changes in that moment, right? And then partners with the right set of companies to deliver that. So I don't think it's one or the other. It has to be a coordinated experience across.
That's a perfect way to wrap up. Thank you guys all for being here and for everything you're doing. You're all doing really important things in this space. So thank you so much.
Thank you.